Say it clearly, say it right, between two voices.
Welcome back. Between Two Voices podcast is here for you, bridging the gap between linguistics and healthcare. So, in our previous encounter with our podcast, we had Ruben Diaz here with us. Can you tell us, what do you do, Ruben?
Well, first of all, again, my name is Ruben Diaz. I am the founder of Titus Language and Educational Services, and I am a service connected submarine sailor.
Well, great. Thank you. And I am Dr. Desiree Diaz, professor and assistant dean for the Master of Nursing program at Vanderbilt University. One of the things I like to engage on a less formal kind of context with you regarding some very important information, but also when it links to patient safety, it's really serious and can affect lots of lives. So in our first session or series, we really delved deep into the foundations of translation, interpretation, healthcare. What is that relationship between both parties as a provider, as someone at the bedside, and working with our trained medical interpreters? What I want to do is focus now on some of the context that might be a little more uncomfortable. So I wanted us to be in a more relaxed. We have our coffee, so grab yours, join a listen with your favorite cup of tea or joe, whatever makes you really start to get your juices flowing in that mindset. And I see you have some coffee there too.
I do.
That is pretty cultural, I must say.
That is very cultural.
Okay, so that will be our segue into cultural brokering and what that means for us when we are looking at working together and partnering together to improve patient safety, patient care, but also quality linguistic access. What does linguistic access mean to a linguist?
Well, the way I would interpret that, pun intended.
Dun. Okay.
The way I would interpret that is the ability for somebody who needs the interpretation or who needs the ability to understand information that is being given to them in a language that is not their own. So that's sort of where we come in. It's to, as it was eloquently put in the video previously, it's to introduce the bridge so the person who is receiving the information or even the person that's giving the information is able to give that adequately and clearly to maximize whatever it is that they're trying to do.
All right, so why don't we have a little video intro for you, the audience, to get a foundation for furthering our conversation.
Awesome. I think that'll be great.
All right, perfect. Let's go. Let's watch together.
So today, we're going to dive into the critical and often invisible world of the medical interpreter. And what we're about to find out is that their job is way more complex than just swapping words from one language to another. It's really about bridging entire worlds. Let me just start with a question for you. What happens when a translation is technically perfect? I mean, word for word accurate, but the communication just fails? It's a situation that can literally have life or death consequences, and it gets right to the heart of what a medical interpreter really does. To really get this, I want you to imagine you're right there in the examination room. You've got a doctor who's trying to figure out what's wrong with the patient, who is obviously in a lot of pain. And the only bridge between these two people, it's the interpreter. So the doctor kicks things off with a super standard, super important question to figure out what's going on. A simple, direct question you've probably been asked a dozen times yourself. Now, the interpreter listens to the patient and gives a flawless, word-for-word translation of what they said. But listen to that response. It's philosophical, right? It's not clinical. It's full of cultural meaning, but it's medically, well, kind of useless. And right there, you can just feel the doctor's frustration. A wall just went up. The doctor needs a number, some hard data, and what they got back was a proverb. The communication is completely breaking down. So what went wrong here? I mean, the translation itself was absolutely perfect. The problem is, the interpreter was only acting in one single role, as a conduit. That's the most basic tool in their kit. And in this case, it just wasn't enough to get the job done. And look, being a conduit is the foundation of all interpreting. It means you are basically an invisible channel for words. You don't add anything, you don't leave anything out, you don't change a thing. You just pass the message along. It's the default, it's the essential starting point. But here's the thing, a really skilled interpreter has a whole toolkit. So let's hit rewind on that exact same moment, but this time the interpreter is going to shift gears and take on a slightly more active role. Okay, this brings us to role number 2, the clarifier. Now the job here isn't just to make sure the words are understood, but that the meaning gets across. They might step in to clear up some confusion or just to make sure everybody's on the same page. And this slide just lays out the difference perfectly. On the left, you've got that conduit translation, total dead end. But on the right, the interpreter becomes a clarifier. By simply reframing the doctor's question for the patient, they get the information they need. It's a small shift, but it's crucial. It gets the whole conversation right back on track. But sometimes the barrier isn't just about confusing words. Sometimes it's a much deeper cultural difference in how we even talk about things like pain or authority or sickness. And that requires a whole other level of skill. So let's talk about the third role, the cultural broker. This is when the interpreter gives the doctor some essential context about the patient's culture, helping to bridge a gap that words alone just can't cross. And this is just a brilliant example of that role in action. Instead of just asking the question again, the interpreter takes a second, turns to the doctor, and offers this one piece of cultural insight. And instantly, the doctor's whole perspective shifts from, "This patient is being difficult," to, "Oh, okay, now I understand why they're answering this way." The entire dynamic in the room just changed. A really great way to picture all this is as a pyramid. The foundation, the place an interpreter spends, say, 95% of their time, is as the conduit. When it's necessary, they step up to become a clarifier, or a bit more occasionally, a cultural broker. And then way up at the very top is the rarest and most complex role of all, the advocate. So how do they know when to switch roles? Well, the guiding principle here is something called the incremental intervention model. Basically, it means an interpreter always starts at the bottom of that pyramid as a neutral conduit. They only move up to a more active role when it is absolutely essential for clear communication, and most importantly, for the patient's well-being. So, that advocate role, the very tip of the pyramid, that's the final step. This is when an interpreter has to actively speak up for a patient, maybe because they see a huge safety risk or a fundamental need that is just being completely ignored. It's a really serious ethical line to cross, and it's saved for only the most critical situations. And that's because the risks of overstepping that line are huge. An interpreter who advocates too soon can start injecting their own opinions, taking control away from the patient, and completely shattering the trust they've built with the doctor. It's a role that carries an immense amount of responsibility. Okay, so now it's your turn. Let me put you in the interpreter's seat. You've got a patient who is refusing a procedure they really need, and it's because of a cultural belief. The doctor is getting desperate, turns to you and says, "Can you convince him?" What do you do? The professional's answer is clear. You do not persuade. That would be a massive overstep. The interpreter's job is to faithfully interpret everything. The doctor's reasoning, the patient's refusal, to make sure both sides understand each other perfectly. They might act as a cultural broker to explain the cultural fear to the doctor, but they have to protect the patient's right to make their own decision. Persuasion is not their role. And all this brings us to a really key takeaway, especially for any healthcare professionals out there. You are a partner in this dance. By speaking directly to your patient, not asking the interpreter, "Can you ask her?" you keep that crucial human connection. Use simple language and trust the interpreter to manage the flow. It lets them do their job, which means you can do your job better and the patient gets better care. Because ultimately, a great medical interpreter isn't just a bilingual dictionary walking around. They are a voice, for sure, but they are also a set of ears, always listening for what's being missed in translation. And when it's needed most, they are a cultural guide, making sure the path to healing is built on a foundation of real, true human understanding.
All right, welcome back. Let's dive into this right from the start. The video talked about the conduit, and I remember when I was really starting to think about linguistic access and what that meant for me. Now, previously you said a language not their own, but some people are truly bilingual but might hear, learn better in a different language that wasn't their necessarily first language. For instance, English wasn't your first language,
Correct.
but what do you prefer to get medical information, English or Spanish?
Oh, that's a great question.
Thank you.
I don't think I think about it. I don't think of it anymore. I often get asked, where did I learn Spanish and how come I speak Spanish so well? And it's because it's my native tongue and because I don't have a thick or heavy Spanish accent. The assumption is that I knew English first and then I learned English second. So for me, I no longer make that distinction of English versus Spanish because I can switch between both languages. I am a native Spanish speaker, but I am a native English speaker level. So I'm at the same level as somebody who learned English as their second language. It's just that I learned it later on in life rather than when I was a kid.
Okay, so here's a first question I'm going to ask. Might be a little thought-provoking, so feel free to take a second, and then we'll go into some of the specifics that we saw in the video. If I am accessing healthcare, and that, let's call it point of entry, so I walk into a clinic, a hospital, ER room, whatever it is, and I have the in-person input intaker, how are they going to know if I should offer you an interpreter or not? What is the baseline? I mean, you have the pulse in this country. What's the baseline there?
I would say that it depends on where that entry level is, because without getting into the specific states and what the federal mandates are and ADA and all these other legislation that is out there in reference that addresses a specific issue, it depends on where. Is it a doctor's office? Is it a hospital? It depends. Even though there is a requirement, there is also a cost involved with that. And we can't, as much as we would like to say it should be everywhere, that cost might be an issue for a small doctor's office. Every time they bring an interpreter, it might not be cost effective. So it depends at that level. Who do you use? Do you need that person just to intake them? So it doesn't require language that's specific to the medical field? It becomes a little sticky when you ask that, because what are we really engaging in? And that's really the question that arises. So
I want to go deeper than that, though.
Okay.
Want to go deeper, not whether I have an in-person interpreter or the telephone interpreters or the video.
Okay.
Even before that, who decides the quality of interpretation that you, the patient, receive? It's a sticky question.
Ooh,
there is no answer to that.
There is
a sticky question.
There is a lot of different. I'll leave it at this. Being somebody who's on this field, and I definitely don't want to throw myself under the bus. One of the things that you need to think about is people that do specific, because I have a couple of these fields that I operate in, things like the legal system, things like the medical system require very specific language. Like, we call in the legal environment, you call it legalese. So it's language that usually happens in a courtroom that people who speak English don't understand it.
But how do we get to that? So I walk up, knock, knock. Hi, I'm Desiree Diaz. I need health care. But maybe I have a strong accent. What decides, you the intaker, whether you're going to offer me interpretation services?
Ask.
Is there any standard?
There is a standard. You should, and that's why I'm trying not to get into legislation, and because every state is different, and there's different requirements. But my thought is, when in doubt, ask.
But how are you going to ask if I don't understand? It's between two voices.
Fair. And oftentimes, now I'm going to change my hats because I need to enter into a cultural brokering position. A lot of times, people who are not originally from whatever country you're in, they feel that showing that you don't understand seems to be exclusive, and you don't want to being perceived a certain way. So I know a specific person that comes to mind that was in the hospital, and that person was asked if she needed an interpreter. She said no, but she absolutely needed an interpreter. So she was receiving information that she could not manage because she didn't understand, not because it wasn't offered to her, but because she chose to say she didn't need one. Call it pride. She didn't want to be excluded. She didn't. It could be a multitude of things.
Mm-hmm.
Until she got in so deep that she had to do, like the Who Wants to Be a Millionaire. You got to call a friend, and she called a friend who happened to be a certified medical interpreter, and said, "Hey, they said this. How is this possible?"
But
And
you're describing the complexities
correct.
of what happens when we don't. So the whole point of that was we bring in biases.
Correct.
So oftentimes your intaker, if it's in a clinic or a hospital setting, something like that, are high school graduates that might not have specific training in identifying who needs an interpreter, who doesn't need an interpreter. That's part one. Then part two is that cultural brokering piece.
Correct.
All to say, it's our responsibility to try to help our patients navigate that space. Now, say we get to the point that we provide interpretation, and whether it be in-person, phone, all of that is, like you said, a financial commitment on the institution and legislation. Now, in the video we watched, we lightly touched on the conduit all the way to the cultural broker and thinking about that partnership. Can you provide some examples of when it's appropriate just to stay the conduit? I personally, as a provider, as a nurse practitioner, I like my medical interpreters just be the conduit. I want to have that relationship, just like I'm looking at you, with you. I don't want to have the conversation with the interpreter and then the interpreter have that relationship, which is in our next episode of some of the semantics and mechanisms of actually how to work together in partnership for the patient.
Right.
But what's an example when being a conduit is absolutely imperative? And then when does that cultural brokering come into play?
So before I go straight into that, I want to back up a little bit. Your previous question, the reason I was giving you so much information is to illuminate on the fact there isn't one answer. There is a multitude of answers, and it depends on so many different things, whether it's scenario, whether it's training, whether it's in so many different things. So there isn't, okay, here's a pamphlet. When you get to here, you split this. It's either yes or no, and then you go into another. It's not that simple. And that's why, as we previously spoke, I'm not worried about AI. AI can't make that determination for us. We have to make that determination as it goes in the actual interaction, and that's the part that's important. So moving now to your question now, a lot of it is I think that I'm going to say it this way because I've been doing this for a long time. The longer you've been doing this, it's not like people say, well, we wear a lot of different hats. You wear all those different places, all those different hats. You wear them all the time, and you glide in and out of those things as needed. There are sometimes contextually you can't be in a conduit because if you translate word for word, it doesn't translate. So you have to have a mastery of grammar to understand what exactly is the provider saying, or whoever's speaking, what exactly they're saying, and how that translates into what it is that you're trying to say. You got to take into it context. You got to take into it, sometimes that person might be from a different country. So I happen to be from Puerto Rico. I can be interpreting from somebody who's from, let's say, Peru. They might have a different word for the same thing. And that's where the more training you have, the more understanding that you have, the longer that you've been doing this, the more you understand, oh, they really mean, oh, that means this to me, but in contextually from where they come from, it's very different. In the video, it mentioned the scale question. Every time I cringe every time that happens, because oftentimes here in the United States,
You're talking about the
providers,
pain scale
the
zero.
pain scale 0 to 10, like,
yeah.
okay, you have pain. Providers here want a number.
Mm-hmm.
Okay. In my experience, being from Puerto Rico, having lived abroad in other Spanish-speaking countries, people don't go to the doctor until they're in so much pain that it's you asking them a number is insulting. So I'm really in pain. I'm not going to take the day off, or I'm not going to stop working to go to a doctor unless, like, my limbs falling off. I mean, obviously I'm exaggerating, but so the fact that you just want a number and you want to minimize the fact that they're in a doctor's office to a number, to some people it could be insulting, and that's cultural. So minimizing that, and I think that that's part of our job of an interpreter. Just, by the way, they're not giving you a soliloquy. You're giving me a proverb, like the video said. It's being able to massage that so you can meet what the patient needs with what the provider needs. And that's why I say the conduit piece. At times, if you're asking for meds, it's a 1-for-1. They said this is what it is. If they're asking for things that are very specific, then 100% you should be, just the conduit. Sometimes the person needs a little more information, and then you need to be a little more specific. And sometimes you just need to clarify, and then that piece comes in. The cultural brokering, like I mentioned earlier, if one country says this versus this country says that. That's just understanding, or sometimes bridging the gap between a Spanish speaker and what country they come from and the perspective here in the United States. And the advocate is the one that I try to stay away from the most.
Why?
Because me personally, I want to make sure that I'm not interjecting my own opinions and my own biases. I mean, I'm former military. So for me, the concept of pain is very different. You do something and you go right along, where culturally, I don't want to impose that on my view on how I feel about that on somebody else's treatment. So I try to stay away from that. Or, it could be a religious thing. I don't want my biases to cloud that patient's treatment, because I'm giving you a response wrapped in my opinion on how, or my bias on how I see their response. So I try to be aware for the patient, but try to remove as much of myself out of that, because as I tell most of the providers that I work with, I'm not here to build a relationship with your patient. I'm just here to facilitate you building your relationship with your patient. I don't want to be seen. I want to act like I'm not here.
Well, you like the conduit piece.
I do.
Better.
I do. I prefer that.
And I know some of that for you, I think, blends in because you are also a certified judicial interpreter.
Yeah,
so in the court of law, you don't want to advocate,
correct,
hey, take
correct.
the plea, don't take the plea.
So.
I think it's a little bit different for the caring profession, where we are trying to work in the best interest of that patient. Whereas in law, something you say may or may not be you're incarcerated, you're not. Here, it's about truly promoting human health, the lived experience, and really having your voice promote what's in their best interest.
Right.
But I think that might be another episode we could do down the line and get maybe other interpreters as what is that feeling for you all? Because your personal beliefs and things when you're advocating, or sometimes we ask you to advocate, hey, they really need to take this medicine. They're not gonna get better. And you do switch out of that. And I really appreciate your profession. I can't do what I do well without you and other trained medical interpreters at my side, because sometimes what I'm trying to purvey to the patient doesn't come across. And then add family members. It's never me and the patient solo in a room. That almost hardly ever happens.
Right.
So I really appreciate your field, your eloquence in that, and blending understanding of medical terminology, but not that, but just human health. So tune in next time as we follow up with medical interpretation and that intersect of human caring and linguistics. Until next time.
Between two voices.
Welcome back with some true or false myth busters. So, Ruben, we're going to see if you can answer some of these myths that we have for our audience. So, let's join in on this conversation. Now, true or false? The provider should utilize the interpreter to explain at their will medical procedures and processes in the healthcare setting.
So false. That's not. That is one of the things that I clarify with my providers, oftentimes right at the beginning. I normally say, just so you know, I don't say something you don't say. So I introduce myself and I lay that
Come
out.
on, you're very verbose. You don't go in at all and explain.
No, not unless I'm asked to. Just because, as I think I had said before, I try to remove myself out of that scenario. Yes, I am part of the team, but the main team members are the provider and the patient. So I serve at the behest of them both. So.
Okay, so
So
you
no, I
hold
don't.
some restraint there.
I do hold.
Only in the work environment.
I do hold restraint in the work environment, and you've seen that. So, so yes, I think
All right,
that
I'll
that's
let you
not
pass on that
something.
one.
That's not something we should do.
So, can you see anything here? Nonverbals.
Okay, yeah, I did.
How do nonverbals?
I didn't know where we were going with those. Okay, I was
How
like,
do nonverbals work? Are you able to interpret patients' nonverbals?
I mean, can we interpret patients on nonverbals? Yes, I think we can interpret patients' nonverbals. The only problem is, how are you interpreting those nonverbals? What oftentimes, and there's where cultural brokering comes in. A lot of times when somebody's speaking to you and you got to think of what countries people are coming from, somebody like a lawyer, a teacher, a doctor, a nurse, are viewed as people of authority. So you look at them respectfully, you treat them with respect. So when they're looking at you and they're talking to you, you might receive that as, and then they shake their head, you shake your head too. You're shaking your head to recognize that they're talking to you and that you're paying attention to them. That doesn't necessarily mean you understood what they said. So culturally, that's more of a sign of respect than a sign of understanding. So it depends. It depends where you're from. It depends. Also, age could contribute to that. And if you're somebody who's older, who comes from a different generation that views certain people as positions of authority, you might be responding with your nonverbals, but what you mean and how it's received, it's very different. So that's one of those things that you got to clarify. Okay, and as an interpreter, here's the part where you're not a conduit. I will step out of my role and ask the person, and I'll tell the provider, did you understand what he said? And then I tell the provider that I asked that, and they'll say X, Y, and Z. and I might ask the provider to repeat what they said.
But
So
let's
I
think
can
about that
repeat
in the
what they
reverse,
said.
in the reverse. So we're trying to really peel away the onion peel of this myth, because coming from the islands, we use a lot of mouth movements like it's over there, So how do you decide to then interpret the nonverbals for the provider?
I always interpret them because I don't want to leave them out. I don't know what I might think I know what they mean,
Okay.
but am I right? So don't leave anything on the table.
So that goes both ways. So for our interpreters watching the podcast, make sure you're interpreting the nonverbals, but also for the providers, the bedside person is understanding there's more to linguistic access and care. And it's a very complex situation with cultural brokering with nonverbals as well. And space too. But that's in another series. We'll talk about space and positioning and all of that. Okay, last one, because these are supposed to be short myth busters, but
Yeah,
we could go on and
Yeah,
have
yeah.
these discussions. Okay, now, is there a time where you have to stay neutral?
Is there a time that we have to stay neutral? Well, oof. I thought you said these were short. We should always stay neutral. We should always stay neutral. I will say that I always take that position initially. I will always stay neutral, in the sense that my services are to both the provider and the patient, and I try to remove myself from that situation. But there's always a but.
Mm.
These interactions are so nuanced at times that there isn't just one acceptable answer. It's not we always do this or we always do that. So to give a really true or false response, I think it would be irresponsible of me to do that, because this profession is literally, you're constantly changing hats. You're constantly changing positions. You're weaving in and out of situations. You have to try to read your patient. And sometimes you have to read the response of the provider that you don't want to say because it might be negative, and you're not trying to pick a side or say, oh, look, they made this comment about the patient and so forth. So it is very nuanced. So you have to take that into consideration. So, I mean, that's a topic for another day. We can really dig deep into that. It also depends on what part of the country you're in and who you're talking about. So,
and I think some of that comes with your linguistic military training too. It's
right.
more cut and dry than what we're dealing with here. So thank you for dispelling some of those things and really being transparent, because as we talk, it's more and more apparent to me that it's more than just having the ability to speak two languages. There's a lot of parts to navigate. And as we move forward in this series, we have utilized simulation to train medical interpreters as well as healthcare providers to use medical services, medical interpretation services with our colleagues. So we'll delve into that in a little bit, that's where I get excited, because there is a skill and an art to work together. It's almost like a waltz for the care of the patient. So tune in next time as Between Two Voices digs deeper and tackles into the nuances of providing care in a partnership with the patient and our medical interpreters. Until next time.
Say it clearly, say it right, between two voices.